Gastric adenocarcinoma is the commonest form of gastric malignancy. It presents a high incidence in Far East and the West Coast of South America, which can be partially attributed to early exposure to environmental factors, to diet, to the prevalence of Helicobacter pylori infection, to genetic factors and to other reasons that so far remain unknown. It seems that during the past 30 years there has been a decrease in its age-standardized incidence and age-standardized mortality, but in absolute numbers we expect an increase of worldwide incidence, and hopefully, a smaller increase of worldwide mortality, due to improved diagnosis and treatment. This increase in absolute numbers, while incidence decreases, is due mostly to East Asian countries represented with the dark green color in this chart. It must be noted that the population of China is responsible for half of this increase. The patient with gastric cancer complains for nonspecific symptoms: postprandial fullness, early satiety, dysphagia, epigastric pain, nausea, loss of appetite, and symptoms secondary to blood loss and chronic anemia. None of these symptoms will raise the suspicion of gastric cancer, except for the limited number of familial gastric cancer, where the family history will raise suspicions. Usually history is unremarkable, and no signs exist on physical examination. If signs are met, they indicate an advanced stage of the disease. A palpable epigastric mass, an enlarged cervical lymph node, the Verkov's node, an enlarged para-umbilical node, the Sister Mary Joseph's node, implants in Douglas pouch known as Bloomer's self, palpable ovaries due to Kirkenberg tumors, palpable liver metastasis, ascites, and cachexia. All these denote widely spread disease with dismal prognosis. It is the clinician's suspicion and thorough investigation that will set the diagnosis promptly, offering the patient a chance for cure. Double contrast studies can easily detect malignancy in expert hands, with high detection rate and sensitivity. With a standardized method, as the one followed in the Japanese screening program, sensitivity can exceed 95%. However, although we get information on the location and extent of disease, we still need tissue biopsy to verify diagnosis. Endoscopy is a reliable method with a high sensitivity which allows tissue biopsy. When biopsies are not possible, brushing and cytology can be of assistance. However, the results of brushing are inferior. Endoscopy must be conducted in a standardized manner, taking at least 8 minutes, so as not to miss any lesion. Newer methods, like chromoendoscopy, magnifying endoscopy, narrowband imaging, confocal laser endomicroscopy will increase the diagnostic ability by guiding the biopsies. Magnifying endoscopy with NBI has already become common in daily practice because it allows the identification of disease, even at its very early stages. Tissue biopsy of any suspicious area will offer histological proof of the disease. In the future, the diagnostic approach may be facilitated by seeking in body fluids like peripheral blood, urine, and gastric juice, specific biomarkers like microRNA, circular RNA, circulating tumor cells, etc. So far, none of these non-invasive methods are part of the standard clinical practice. Having set the diagnosis, a classification of the cancer type will assist in prognosis and treatment. Borman classified gastric cancer according to its macroscopic appearance. It can be either polypoid, or fungating, or ulcerative, or flat and diffuse. Flat type carries the worst prognosis while polypoid carries the best. Lauren's classification is based on tumor histology. It is still valid and the most used. Cancer is classified into intestinal type when glands are formed, cell cohesion exists, and there is a tendency of the cells towards intestinal differentiation. This cancer commonly spreads in lymph nodes, or the liver. In diffuse type, the cohesion among the cells is poor, few glands can be seen, and the cancer spreads towards lymph nodes or peritoneal cavity. Diffuse gastric cancer has a bad prognosis. Mixed and indeterminate types also exist. WHO classified gastric cancer into tubular, papillary, mucinous, and poor cohesion type. The first 3 types are equivalent to the intestinal type in Lauren's classification, while the last one is the diffuse type according to Lauren. A molecular classification based on the expression of various genes has also been proposed. There are differences among proximal non-diffuse cancer, distal non-diffuse cancer, and diffuse cancer. However, no clinical utility of this classification has been described so far. In contrast, the classification derived from the Human Genome Project has therapeutic implications. It discriminates adenocarcinomas into those that carry genetic material of the Epstein-Barr virus, those that are characterized by microsatellite instability, those that are characterized by stable genome, and those characterized by chromosomal instability. The first two categories can be successfully dealt with immunotherapy. Gastric cancer is also classified according to cell differentiation and grading. In grade 1 the cells are large and normal looking. In grade 2 cellular polymorphism, and in grade 3 nuclear polymorphism exist. Loss of gland formation and cellular differentiation represent grade 4 cancer. The higher the grade, the worse the behavior and the prognosis. Gastric cancer appears initially in the epithelium. As it grows, it gradually infiltrates the surrounding tissue and spreads across the gastric wall. As long as it remains above the basic membrane, it is absolutely superficial and called in situ. Breaking the basic membrane allows cancer to infiltrate all the layers across the gastric wall one by one. Infiltrating the lamina propria and the muscularis mucosa, the cancer cells reach the submucosa. Submucosa is rich in anastomotic networks of lymph and blood vessels. Entering these vessels by intravasation leads to lymphatic or hematogenous metastases. Further growth and infiltration of the muscularis propria, and then of the serosa, allows cancer cells to reach the abdominal cavity. Now they can either spread freely in the peritoneal cavity, giving rise to peritoneal implants, or they can infiltrate adjacent organs, for example the left lobe of the liver. With the diagnosis and the localization of the disease known and verified by pathology, the clinical workflow proceeds into assessing the status of the patient and quantifying the extent and spread of the disease. This quantification is commonly called staging. It follows the TNM system, in which the primary is represented in the T component, the nodal spread is represented in the N component, and distant metastasis in the M. The T component describes the depth of infiltration of the gastric wall by cancer. T in situ is intraepithelial cancer above the basement membrane. Mucosal cancer is symbolized by T1A. Infiltration of the submucosa is T1B. Of the muscularis propria, it is T2, and of subserosa is T3. When cancer infiltrates the serosa, it is T4A, and when it infiltrates an adjacent organ, it's T4B. The N component describes local and regional lymph node metastasis, corresponds to the number of nodes infiltrated by the disease. Locoregional lymph nodes are those included in the first and the second tier, while para-aortic nodes of the third tier represent distant metastases. N1 denotes up to 2 nodes infiltrated, N2 up to 6, N3A up to 15, and N3B more than 16 nodes infiltrated. M0 denotes that there are no distant metastases, and M1 denotes that there is distant metastasis, either hematogenous or lymphatic, or that there is peritoneal dissemination. The disease can be staged overall with the clinical TNM information, and the prognosis by stage can be seen in the survival curves. Special consideration should be given to early gastric cancer. This is defined as the cancer infiltrating up to the submucosa but not the muscular layer of the gastric wall, and this, regardless of lymph node metastasis or lymphovascular invasion. Lymph node metastases exist in only 3% when cancer is limited to mucosa, and in 25% when it is limited in the submucosa. Thus, early gastric cancer has less chances of having spread, and a radical surgical operation may offer cure. Indeed, a 70 to 95% 5-year survival is achieved by surgery alone. Staging typically begins with a computerized tomography, performed with a specific protocol and diagnosed by devoted radiologists. After 6 hours of fasting, the patient is positioned supine, or prone, depending on the tumor location. The gastric lumen is opacified with water, and spasmolytics aid in ballooning the stomach. Intravenous contrast is also used. T-stage is determined with specific radiologic criteria, such as the appearance of the outer surface of the stomach, or of the perigastric fat. For end-stage, the size, shape, and texture of lymph nodes are assessed. M-stage can be determined by direct evidence like deposits or metastases, or indirectly by serosal involvement, ascites, etc. A T2 with regular surface of outer layer and normal perigastric fat. A T3 with irregular surface of outer layer of gastric wall. A T4B with extension of the tumor into the liver. A T2N plus cancer with regular surface of outer layer and an enlarged rounded lymph node of the left gastric artery. In general, contrast-enhanced multi-detector CT is very accurate. Its major weakness is the lack of specificity for nodal disease, and the low sensitivity for the tiny peritoneal implants. Additional information can be retrieved with endoscopic ultrasound, briefly called EUS, where the gastric wall layering as well as nodal involvement can be appreciated. EUS can discriminate effectively early gastric cancer from advanced cancer but is not equally effective in discriminating mucosal from submucosal disease. This, much needed information, is useful in clinical practice because patients with mucosal disease are potential candidates for endoscopic treatment. Regarding lymph nodes, EUS is sensitive, but not specific, in detecting nodal disease. However, it can always guide FNA, increasing thus the specificity of the method. MRI offers no additional information compared to the combination of CT scan with EUS, but is helpful when either contrast-enhanced CT or EUS cannot be performed. PET-CT use is limited by the low uptake of fluorodeoxyglucose in several cancer types. It offers no additional information, although recently it was reported to detect unsuspected metastases in 3 to 7% of the patients. In contrast, staging laparoscopy and cytology of peritoneal lavage is of great value, because it will reveal unsuspected hematogenous spread or peritoneal dissemination, i.e. stage 4 disease, and change therapeutic decision in a significant percentage of patients. Staging laparoscopy and peritoneal lavage should be applied in all patients with stage higher than 1B, with signs of aggressiveness such as high-grade, lymphovascular or perineural invasion or Bormann type 3 or 4. The same staging workflow can be applied after neoadjuvant, preoperative chemotherapy. In this case, although staging is not equally accurate, it will offer valuable information on the residual disease, but more importantly, on the response of the disease to treatment. Treatment strategy should be planned in a multidisciplinary frame, and may include other modalities, but resection remains mandatory, if we aim to patient cure. It should be individualized according to disease type, disease stage, and patient status. Stage 1 disease is restricted locally, and can be successfully dealt with resection, be that endoscopic, be that surgical. Stage 2 and 3 diseases have spread regionally, and necessitate the addition of chemotherapy, or rarely, radiotherapy. Stage 4 disease, with distant spread, cannot be cured. Its treatment should be systemic. The role of surgery is limited to palliation, however, this has been questioned recently, as in selected cases aggressive treatment of metastasis benefits the patient. Depending on the localization of the tumor, gastrectomy can be total or partial. Partial gastrectomy can be proximal, or distal. Provided that an R0 operation has been performed, and that resection margins are of sufficient length, all operations have equivalent outcomes in terms of survival and recurrence. Proximal gastrectomy is not a common operation, because reconstruction is difficult with late reflux symptoms and anastomotic strictures, while there is no functional benefit compared to total gastrectomy. Distal gastrectomy, on the other hand, offers a better quality of life, at least for the first post-operative couple of years. The distal resection margin of gastrectomy is duodenum. The resection line should typically be 5 cm away from the tumor, although recent research questions this length. In the case of total gastrectomy, or proximal gastrectomy, The proximal resection line is the gastroesophageal junction. The possibility of lymphatic spread in mucosal cancer is 3 to 5%, and when submucosa has been infiltrated, it rises to 16 to 25%. Infiltration of muscularis propria and beyond increases the possibility to 80 to 90%. Accordingly, there is minimal need for lymphadenectomy in T1A, mucosal cancer. In T1B, submucosal and beyond disease, resection of the first and second tier of lymph nodes is mandatory. In surgical terminology, resection of the first tier, i.e. the perigastric lymph nodes, is called D1 lymphadenectomy. Resection of the second tier, which practically consists of the regional nodes, is called D2 lymphadenectomy. These include the lymph nodes along the left gastric artery, the common and the proper hepatic artery, the splenic artery, and the celiac artery. More aggressive resections, such as splenectomy and distal pancreatectomy, are not indicated unless these organs are directly infiltrated by cancer. Bursectomy, i.e., the decortication of the lesser sac by denuding transverse mesocolon and pancreas, offers no benefit except for a very limited number of patients. Reconstruction of the continuity of the alimentary tract can be with Billroth 1, Billroth 2, and Roux-en-Y anastomosis, each one presenting its own advantages and disadvantages as previously analyzed. Provided some criteria are met, surgical resection can be replaced by endoscopic resection. Cancer must be of intestinal type, well differentiated, not invading beyond the first third of the submucosa, T1B, SM1, with absence of lymphovascular or perineural invasion, not ulcerated, and of course, with no evidence of lymphadenopathy. In these cases, endoscopic resection is oncologically safe and beneficial for the patient. If the lesion is less than 2 cm in size, it can be resected with endoscopic mucosal resection, commonly called EMR. In this, the lesion is lifted with a forceps, with suction, or by injecting saline in the submucosa, and resected with a cautery loop. When the lesion is larger than 2 cm, endoscopic submucosal dissection, commonly called ESD, is preferred instead of a piecemeal EMR. The lesion is again lifted by submucosal injection of colored saline, demarginated, and resected in one piece. ESD is time-consuming, more difficult than EMR, and needs special instruments like the IT knife. However, it spares the patient a surgical operation, provided that the criteria are met in pathology. If the pathology report is not satisfactory, then the patient must be operated upon. In these cases of early gastric cancer, limited gastrectomy combined with limited lymphadenectomy, as performed in the East, may suffice. So far this has not been the standard of care in the West, where a formal gastrectomy with a D2, or commonly a D1+, or lymphadenectomy is the typical operation. For those patients with a higher stage of disease, a typical gastrectomy with resection of the major omentum plus D2 lymphadenectomy is the indicated procedure. Like all procedures in surgical oncology, the goal is an R0 operation, leaving behind no microscopic R1 resection, or, even worse, macroscopic R2 resection, disease. Minimally invasive surgery is the new trend in surgical oncology of the stomach. There is enough evidence that it benefits the patient with early gastric cancer. Unfortunately, there is no similar evidence for the patients with advanced gastric cancer, who are the vast majority in the West. Survival and recurrence rates are similar with the open and the minimally invasive approach, indicating non-inferiority. Minimally invasive surgery offers the following measurable benefits for the patient: approximately 1 day shorter hospitalization, and less than half of a blood unit of transfusion. This gain is counterbalanced by the prolongation of operative time by up to 90 minutes in expert hands. Therefore, minimal invasive surgery can be an alternative of open surgery. After upfront surgery, if the pathological examination reveals no lymph node disease, 5-year survival will be around 75%. If the lymph nodes have been infiltrated, then the 5-year survival drops to 10 to 30%. These patients should receive adjuvant treatment. Similarly, the unfortunate patients who ended up with an R1 or R2 operation need adjuvant treatment too. This can be chemotherapy or chemoradiotherapy. Post-operative adjuvant chemotherapy increases survival. The same is achieved with chemoradiotherapy. But chemoradiotherapy offers no additional benefit compared to plain chemotherapy, so it is mostly abandoned. For elective cases where the operation is not an emergency, the current strategy is perioperative chemotherapy. This means preoperative chemotherapy, followed by surgery, and then post-operative chemotherapy. As summarized by ESMO, perioperative chemotherapy adds more than 10% in the 5-year survival. In the same table we can also see that evolution and standardization of surgical technique improved the outcome of surgery. Of course, in the acute setting, with emergency gastrectomy, perioperative chemotherapy is not an option, and adjuvant chemotherapy is the standard of care. Gaining insight on the biology of gastric cancer has led to the development of targeted treatments. Patients harboring a HER2, CERB2, mutation will benefit from the addition of trastuzumab in their regimen. Treating patients with monoclonal antibodies, regardless of their stage, even in stage 4, terminal disease, improves survival as shown here. Furthermore, both the MSI and Epstein-Barr virus positive gastric cancer patients present increased expression of PD-L1. Immunotherapy with anti-PD-1 and anti-PD-L1 antibodies activates programmed death and apoptosis in cancer cells selectively. The results in recurrent, metastatic, or unresectable gastric cancer have been encouraging, so research has now focused on the role of immunotherapy in the neoadjuvant setting, with promising results so far. Terminal stage patients should be offered palliative treatment and best supportive care. This includes palliative gastrectomy, stenting or bypass operations to relieve obstruction, palliative chemotherapy or radiotherapy, targeted therapy or immunotherapy, and of course, best supportive care. Life expectancy is short, and what matters most is minimal suffering and preservation of the patient's dignity and self-respect.